Now for integumentary key terms. We're going to identify the primary skin lesions within this video. So starting with the name here, a mole. The medical term is a nevus or a nevus, and the description is a growth on the skin. Now it's cancerous if it's uneven or irregularly shaped. The next is a macule, which the medical term is also macule. So the description is a flat, discolored area on the skin less than 1 centimeter wide. And a great example is freckles or even tattoos. Now the next key term is boils or even pimple. This is known as a papule, which is a red raised area of skin tissue about 1 centimeter. So acne, warts, and even insect bites would be classified as a papule. Next is a lump or bump described as a nodule. It's a lump underneath the skin that's at least 1 centimeter in size. And a great example is a granuloma with rheumatoid arthritis. Next is the tumor. Now the medical term is a neoplasm. So it's a mass formed when normal cells begin to change and grow uncontrollably. So benign is non-cancerous and malignant is cancerous. Great examples are BPH or even brain tumors. Okay, the next one is pretty simple here. A plaque, also called in medical terminology, just plaque. Now it's described as fast growth of skin cells that appear in a few small spots, looking similar to dandruff. And a great example is psoriasis and even eczema. Next we have hives and wheals. This is known as urticaria. Now it's not exactly the same, but it typically happens within the same reaction to an allergen. We see superficial skin coloring or pale skin swelling, usually surrounded by erythema, that red skin, that lasts anywhere between a few minutes to a few hours. And a great example is heat hives. Now lastly, we have blisters. The medical term is a vesicle, which we all know what a blister looks like. It's a small fluid-filled blister on the skin. And a great example is from burn patients. All right, that wraps it up. Thank you so much. Our next topic is burns. Burns are injuries caused by direct tissue damage from exposure to either the sun, chemicals, thermal like boiling liquids, and even electricity. Now, as you know, the skin is made of 3 layers: the epidermis, the dermis, and the subcutaneous tissue, that fatty, bubbly looking tissue. Now, after the layers of skin, we find fascia, muscle, and then bone. So in first degree or superficial burns, we have damage to the epidermis, the top layer. So we see dry with blanchable redness, meaning that when you press on the wound, the redness goes away. Now second degree burns, called partial thickness burns, we have both the epidermis and dermis that are damaged. So the key sign to know is painful blisters, huge NCLEX tip. So write down these keywords here: red, moist, and shiny fluid-filled vesicles, or basically blisters that often leak fluid. So just think 2 layers of skin for 2-degree burns, or second-degree burns. Now third-degree burns are full-thickness burns. We have 3 layers of skin destruction: the epidermis, the dermis, and possible subcutaneous tissue, described as key terms: dry, waxy white, leathery, or even charred black color that is non-blanchable skin. Big key terms for exams. Now, 4th degree, also a full thickness burn. These are the worst burns by far, as they go through all the layers of skin down to the muscles and even the bones. A unique sign is the lack of pain, since the destruction of nerve endings from all the burn charred areas. Even though they may look similar to 3rd degree burns, these are far worse since they're far deeper. Now, for minor burns, like the 1st and 2nd degree burns, these do not typically need hospitalization and can be treated outpatient with wound care and dressing changes. Whereas major burns like 3rd degree and 4th degree, these are deadly medical emergencies requiring intensive care, which we'll cover in a moment. So first, care for minor burns. Say a client is cooking and then burns themselves. Or say they spill a boiling pot of water on an extremity. So we always teach the 3 C's for pre-hospital care: cool water, cover the area, and clothing removal. So for pre-hospital care, C for cool water, key terms, is briefly soak the area. And no ice, no creams, and definitely no antibiotic ointment to open skin. The key term there is open skin. So this can lead to additional damage, and the creams, lotions, and antibiotics may interfere with the assessment from the healthcare provider. Now the second C is cover the area with key term, clean, dry cloth. So write that down. This is done to prevent infection and more damage in the pre-hospital setting. And the last C is clothing and jewelry removal near the burn, if not adhering to the burned skin. Only the HCP should remove anything adhering to the burned skin. So please be sure to write that down. Now Saunders mentions, the nurse instructs firefighters that in the event of a tar burn, which is the immediate action? Cooling the injury with water. Yes, that was our first C there. And the second question, for a chemical burn injury, the nurse instructs the employees that which is the first consideration in immediate care? Removing all clothing, gloves, and shoes, and any undergarments. Just strip down like you're going skinny dipping. Now for Kaplan, they mention discharge teaching to a client with partial thickness burns, or second degree burns, on the hand. We wrap the fingers with individual dressings. This is done to prevent tissues from sticking together and causing further damage. Now for the big mama, the pathophysiology for major burns. These can cause massive tissue damage and cellular destruction, resulting in widespread systemic inflammation that increases vascular permeability or capillary permeability. Just really fancy words for leaky blood vessels that fill up the body like a water balloon. So fluid, electrolytes, proteins, and other contents just spill over into the interstitial spaces, or the third spaces. Clients end up with severely low fluid volume intravascularly within the blood vessels, as fluid and electrolytes escape and now go into the tissues, eventually progressing into deadly hypovolemic shock. That severely low blood pressure that eventually causes death. This is why the number one intervention for major burns in the first 24 hours, and big NCLEX tip, so write down these key terms: IV lactated ringers, or LR solution, and IV normal saline, that 0.9% sodium chloride. These two will help save lives. They are isotonic fluids, which we call isoperfect fluids, since they stay inside the veins longer than any other solution, as it closely resembles the chemical composition of human blood. Fancy words for it increases the fluid volume inside the blood vessels, increasing the blood pressure and saving your patient's life. So don't let the NCLEX trick you here. We're not administering 5% dextrose, that glucose in water, which is not an isotonic solution, and not 45% normal saline, or 0.45%. That's a hypotonic solution. Only isotonic solutions here. So write it down again. Lactated ringers or normal saline. Biggest NCLEX tip. So Kaplan mentions, the nurse is caring for a client with full thickness burns covering 20% of their body. What is the priority of care after ensuring a patent airway? IV fluids. And Saunders mentions, extensive burn injury, 45% of the total body surface area. Planning for fluid resuscitation, the nurse should consider that fluid shifts to the interstitial spaces is greatest during which period of time? Between 18 and 24 hours after the injury. Yes, the key term here is before or within 24 hours of the injury. Fluid resuscitation is priority, with normal saline and lactated ringers are isotonic solutions. So please be sure to write that down. That will save a life, and it's the most tested. Now for the big signs and symptoms of major burns. These ones love to show up on exams. The key point is that in the first 24 hours, as cells burst and cellular damage occurs, the cells release potassium into the bloodstream, causing high potassium, that hyperkalemia over 5.0. So just think, potassium is priority since it pumps the heart muscles. So with high potassium, we have high pumps of the heart, leading to key terms, tall peaked T waves on the ECG monitor, huge NCLEX tip, and a big priority, because this could lead to deadly cardiac dysrhythmias, making potassium always the number one priority. Now, some other expected findings. We see low potassium, that hyponatremia, below 135, another big NCLEX tip, so write down that key number. Sodium is lost as fluid shifts within the blood vessels and into the tissues here. So just think where fluids flow, electrolytes go! Now, don't let the NCLEX trick you here. Potassium is the priority here, with all those peak T waves that can lead to cardiac dysrhythmias and kill your patient. So remember, focus on any potassium higher than 5.0, because that is the priority. Now lastly, elevated H&H. So we'll see a hemoglobin that is elevated, normally between 12 and 18, and hematocrit is normally between 36 and 54%. But naturally, both of these will be elevated due to the low blood fluid volume, that hypovolemia, making the remaining blood very thick and hemoconcentrated. So that's why we see an H&H that is high when the body is dry. Now, Saunders mentions severe burn injury that covers 35% of the total body surface area. The nurse is most likely to note which finding on the laboratory report. A hematocrit of 60%. Yes, that is elevated, indicating hemoconcentration. Now, for the rule of nines. For your NCLEX and your exams, you must know how to calculate the rule of nines. Over 70% of students get these questions wrong, so be sure to listen close. A big test tip here is I recommend to write out this chart at least 10 times every single day the week of your exam. It's kind of like lab values. You need to know your numbers here. Okay, now as you can see, the rule of nines is used to quickly estimate the percentage of the body affected by a burn. This is called total body surface area, and it's used to calculate the exact necessary fluid resuscitation that is needed and require level of care for the client. So for example, the head and the neck are 9% total, 4.5% for the front and 4.5% for the back, aka anterior for the front and posterior for the back. Now the arms account for 9% total. Once again, 4.5% for the front, the anterior part, and 4.5% for the back, the posterior. And the same thing for the legs, but this is 18% total. So 9% for the front and 9% for the back. Now the most interesting part here is there's only 1% for the perineum. Wait, what? 1%? Okay, yeah. One, womp, womp, womp. Okay, now a commonly missed question here. A client has a full thickness burn to all the posterior body surfaces. Using the rule of nines, calculate the percentage of total body surface area that is affected. Guys, a lot of students get these wrong, so you must know your rule of nines numbers. Okay, now looking at the chart here that we memorized, we know that only the posterior body surfaces are affected from the question. So 4.5% for the head, 18% for the entire back, 9% for the right and left arm, and 18% for the right and left leg. So the answer is 49.5%. Now most exams ask you to round to the nearest whole number. So the answer would be 50% of the body, which makes sense because the entire back or posterior of the body has been burned here. So half the body's been burned, so 50% of the body. Now the next top missed question. The client has partial thickness burns to the anterior legs and perineum. Ouch. Using the rule of nines, calculate the percentage of total body surface area affected. Okay, so anterior legs and perineum, which includes that measly little 1% for the peri area, womp womp womp, and 18% for the right and left leg, since only the anterior is affected, or the front. So the answer is 18 plus 1 is 19%. Now, once the total body surface area is calculated, then the volume needed for emergency fluid resuscitation within the first 24 hours can be calculated, using the Parkland formula. So write this down. We take 4 milliliters multiplied by the kilograms of body weight and the total body surface area percentage. Now, this is not commonly tested on the NCLEX, so I wouldn't freak out too much, but it may show up on your nursing school exams. So let's do a quick little example. Taking from our previous question, let's say the client weighed about 100 kilograms with that 19% total body surface area affected. Now we're calculating the lactated ringer fluid of resuscitation needed. So using the formula, we're taking 4 mLs times 100 kilograms, let's just say, and from the previous question, 19% total body surface area. You take those bad boys, multiply them together, and the answer is 7,600 milliliters within the first 24 hours. Now, we give the first half of fluid in the first 8 hours of the incident, so around 3,800 mLs, and the remaining fluid we deliver over the next 16 hours, another 3,800 mLs. But again, I wouldn't focus on this too much for the NCLEX. This is mostly used for your nursing exams. Now for the treatments of major burns, as mentioned before, during the emergent phase, the number one intervention in the first 24 hours, hopefully you wrote this down, we give isotonic solutions like IV lactated ringers and IV normal saline. Now, how do we know if fluid resuscitation is working or not? Well, the assessment of fluid resuscitation, big key term here, urine output 30 mLs or more. Huge NCLEX tip. Make sure to write that down. Urine output is a vital sign that indicates fluid resuscitation has been effective. So that's why we say 30 mLs per hour or less means the kidneys are in distress. Now the second key point of fluid resuscitation is blood pressure. So 90 systolic or more and a heart rate less than 120 beats per minute. This means that fluid resuscitation has been effective. So I'd recommend pausing your screen and jotting these down. These were the most tested for fluid resuscitation. So don't let the NCLEX trick you here. Electrolyte balance is not the best indicator of fluid resuscitation. It's always urine output, then BP, and then heart rate, the top 3 there. So Saunders mentions, a client undergoing fluid replacement after being burned 20% of their body about 12 hours ago. The blood pressure is pretty low, 90/50, a pulse rate of 110, and a urine output of 20 mLs over the past hour. The nurse anticipates which prescription. Okay, so look at the key terms here. The BP is definitely not looking good. We're probably going to slip into hypovolemic shock for sure. So increasing the IV lactated ringer solution is the best option. Now, once the client shows adequate urine output and urinating or diuresing over 30 mLs per hour, then we can administer enteral feedings once bell sounds return. Nutrition is always a priority, but only after fluid resuscitation. This helps the client meet caloric intake required to rebuild damaged tissues from a burn. Now, as the body heals with open wounds from major burns, infection is a huge deadly risk here. So Kaplan mentions, a patient with burns who is immunocompromised, what precautions should be taken to prevent infection? Now, the key words here are immunocompromised and prevent infection. So avoid placing fresh flowers or plants in or near the client's room. Yes, we always want to avoid crowds, fresh fruits, and all the typical stuff for clients who are immunocompromised to prevent infection. Now, during the rehabilitation phase, this happens when wounds fully heal and typically takes around 12 months or so, depending on the severity of the burns. Now, the big key point to write down is that infection is not a big risk here. As wounds have been fully healed, there's no more open sores. So don't let the NCLEX trick you here. Infection is not a big risk. 80% of students get this wrong. So pay attention to the W's here for patient education. Big NCLEX tips. First W is for water-based lotion, which helps to minimize itching and scarring to allow the skin to fully heal. The second W is to wear pressure garments. Yes, don't let the NCLEX trick you here. Wearing pressure garments are good to help minimize scarring. It also helps to keep the skin and tissues tight while promoting circulation to be able to fully heal. And E is for exercise daily with range of motion. This helps to promote movement and prevent stiff joints, and we always encourage sunscreen and protective clothing when going out in the open sun to prevent those darn sunburns. Alright, that wraps it up. Thank you so much for watching. Now for the practice questions on burns. Question 1. The nurse caring for a client with partial thickness burns expects which findings upon assessment? So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down, following the question breakdown strategy. So number 1, first look at the key terms in the question. Partial thickness burns, and the question is asking for which findings upon assessment. So the second thing is think of a few things you know about those key terms. Remember from the full video, partial thickness means second-degree burn. So painful blisters with key terms here: red, moist, shiny, fluid-filled vesicles. Basically, blisters. Okay, now let's look at the options. So option A, areas of painful redness without elevation. No, this is incorrect. It is painful and red, but partial thickness second-degree burns do have elevation with those blisters or those fluid-filled vesicles. Now option B, areas of painful fluid-filled blisters. Yes, the key term there is fluid-filled blisters. So this is the most correct, as all the key terms are there. Now option C is incorrect. Areas of dry, painless, leathery skin. So this is not mentioning of blisters. Remember, dry, painless skin is usually that of a third-degree problem. Now option D, also incorrect. Areas of black, cherry red, or white patches. No, so this is incorrect because areas of black skin can either be third or fourth degree, but it's most likely fourth degree. Now moving on to question 2. The nurse is assessing a client with severe full thickness burns. The client suffered burns to the front and back of the head, the right arm, and chest. Using the rule of nines, what percentage of the body is burned? So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down following the question breakdown strategy. So number 1, first look at the key terms in the question. Severe full thickness burns to the front and back of the head, right arm, and chest. So using the rule of nines, let's break it down. So front and back of the head is 9%, basically 4.5% for both sides. The right arm is also 9%, with 4.5 accounting for both sides. And the chest is only 9%. So add 9 times 3 and we get 27%. So option A would be the most correct. All right, that wraps it up. Thank you so much for watching. So the pathophysiology, it's a bacterial skin infection of the deep dermis and subcutaneous tissues, typically caused by a staph infection, like Staphylococcus aureus. Now, it's normally found in a lower limb, near the tibia, for example. So Hesse mentions, swab culture for cellulitis infection. The nurse anticipates the culture will grow which causative specimen of bacteria? Staphylococcus aureus. Now for the risk factors, this includes patients with trauma, a history of diabetes, and even history of cellulitis, and history of athlete's foot, that tinea pedis, basically a fungal infection, as well as lymphedema, obesity, and even venous insufficiencies, where blood flow is limited to the lower legs. Now for signs and symptoms, just think about cellulitis. We have inflammation and infection. So it includes a fever because of the infection, as well as pain, warmth, tenderness, and swelling and erythema, or patches of redness to the affected area. If untreated, it can grow into an abscess, basically a big ball of infection, and then lead to sepsis and chronic edema. So Hesse mentions, a patient with a fever has erythema, pain, and tenderness over an area of skin. Which infection does the nurse suspect in the patient? So the key terms here are fever, erythema, and pain over the skin. So skin is a huge key term. So cellulitis is the answer. And another question, which statements regarding cellulitis are true? Select all that apply. Complications can include sepsis, yes. It can include an abscess if left undiagnosed and untreated, yes, also true. It occurs when bacteria enters the body through a break in the skin, yes. And it can spread by direct contact with open area on a person who has an infection. All are true. All right, that wraps it up. Thank you so much for watching. Now for atopic dermatitis versus contact dermatitis. So starting with atopic, also called eczema. This is a condition wherein patches of the skin become inflamed, itchy, cracked, and rough. Sometimes they can also cause blisters. It is an autoimmune disease, meaning the body attacks itself, attacking the skin. And it tends to flare up periodically when exposed to allergens. Now the main cause is inherited, or basically genetics, and it's very common in infancy, but can happen at any age. Now the manifestations to write down. We see chronic inflammation of the skin, as well as erythematous rash with serous exudate. Fancy words for a red rash that might be leaking pus. Now for contact dermatitis, this is a condition that makes skin red or inflamed after contact with an allergen or irritant. Now it's very different than atopic dermatitis in that it's caused by an irritant outside the body. For example, an exposure to an allergen like poison ivy. So we see a pruritic rash within hours. There's no immune response necessarily because it's direct exposure and an inflammatory response. Now for interventions, big NCLEX tips. So I'd write these down. We must trim nails to avoid scratching. Number 2, use lukewarm or tepid sponge baths with soap. We really want to avoid long baths that are too hot, as they may dry out skin even more. So write this down. We pat dry with towels and never rub. And apply moisturizer immediately after bathing. The goal here is to keep the skin moisturized. And lastly, we always recommend cotton clothing because it's soft to prevent itching. Never wool clothing. This is rough fabric and this could intensify itching. So again, write these down. They love to show up on Select All That Apply questions. All right, that wraps it up. Thank you. Now for shingles, also called herpes zoster. It's caused by reactivation of varicella zoster virus, which is the virus that causes chickenpox. So patients that have had chickenpox as a child are most likely to get shingles in older age. This kind of virus is an opportunistic infection, meaning that it waits till the body's defenses are weak before attacking. So the risk factors are pretty simple. Just think of a client whose defenses are down, called immunocompromised, or a compromised immune system. Say a weak immune system like clients on immunosuppressants, or clients undergoing chemotherapy, or even clients fighting off another infection like pneumonia, where the immune system is preoccupied fighting another battle. Now, other causes include poor nutrition or even too much stress and fatigue, like recovering from surgery, or even like students in nursing school or those preparing for the NCLEX. We're talking lots of stress here. Now, the HESI mentions risk factors for shingle outbreak. Select all that apply. So a client who's had the chickenpox as a child, admitted to the hospital for pneumonia, or even a client who's stressed about finances because the spouse is battling with cancer. Yes, all are risk factors. Now, in terms of signs and symptoms, we have a rash that runs horizontally along the left and right side of the torso. Now, the rash can present vascular, pustular, or even crusty, with a low-grade fever and paresthesias, that burning and numbness and tingling. And the treatment is pretty simple. We isolate the patient in a negative airflow room until vesicles are crusted over, and avoid exposure to anyone who has not had or been vaccinated against chickenpox. And lastly, we administer antiviral medications like acyclovir, as well as give analgesics for the pain. So let's play that segment now from our pharmacology master course. These guys end in cyclovir, like acyclovir and valacyclovir. Now they kind of sound like circle here since herpes sort of look like circles. And you can remember the vir is used to treat the viruses like certain types of herpes. So herpes genital and cold sores and herpes zoster, which are shingles. Now the big key points here, guys, write these ones down. We take daily, and also there's no cure since it only slows the virus. And big one here, you avoid sex while lesions are present. Guys, there were like 3 HESI exit questions about that. Lastly, we drink extra fluids, and it's also effective for less frequent eruption of lesions. Big keywords right there. All right, that wraps it up. Thank you so much for watching. It's a very common, highly contagious skin infection affecting infants and children. So the memory trick, just think infantigo is for infant tigo. Now it's caused by a strep or a staph infection, which is really dangerous in children as that strep infection can travel all the way down to the kidneys, causing glomerulonephritis, secondary to a streptococcus infection. Be sure to write that down. This is highly tested on the NCLEX. Because remember, the most deadly complications are typically the most tested complications. So once again, glomerulonephritis secondary to a strep infection. Now for signs and symptoms, we see itchy red sores mainly on the nose and mouth, as well as the hands and feet. Now these sores can burst and dry into honey-colored crusts. This is when the infection is the most contagious and most easily spread. Now, a more serious form of infantigo is called ecthyma, where it penetrates deeper into the skin, causing painful fluid or pus-filled sores that turn into deep ulcers. And it spreads when a child has open sores or items they've touched, such as clothing, bed linen, towels, and even toys. So for treatments, the big NCLEX tips. Be sure to write these down. They love to come up on Select All That Apply questions. So number 1 is no school or daycare to prevent the spread of the infection, especially when there are open sores. Number 2, we always wash hands before and after touching infected areas. Number 3 is separate the child's clothes and towels from other laundry, and always wash with hot water. And number 4 here is short and filed fingernails. Because of the itchy skin, we want to decrease the risk of causing more open sores. And number 5 is softly remove crust and debris from those open sores, as mentioned by Kaplan. So HESI mentions, a child has infantigo. What actions should the nurse take? Send the child home with the parents to see the HCP. And Kaplan, care for a child with infantigo. Which information does the nurse include in the teaching plan? Soften and remove crust and debris. All right, that wraps it up. Thank you. Now for pressure injuries, formerly called pressure ulcers. These result from damage to the skin or underlying tissues over a bony prominence, commonly from bedridden clients who are not turned adequately, or from a medical device due to intense or prolonged pressure, like long-term use of oxygen devices, like a nasal cannula or even an oxygen face mask. But typically bed sores are the most tested here, resulting from bony prominences, basically areas that feel bony. So the top 3 most common areas are the lower back and buttocks, including the sacrum and coccyx, the heels and the ankles, and even the hip bones, very bony areas. These 3 are the most common areas for pressure injuries, but even the shoulder area like the scapula and the elbows are high risks. Now in terms of the causes and risk factors, just think of the patho here. The skin is breaking down from all that pressure, as well as other factors that can make the skin weak. So write this down. Bedridden clients who are immobile from either neuro issues, spinal injuries, or just intubated and sedated. Whatever the cause, being in bed for long periods of time degrades the skin. Secondly is incontinence, or having a wet bed, where clients can't keep urine in with incontinence. Now, wet skin leads to skin breakdown. Another cause is from poor nutrition, with low protein or low fluid intake. This puts the skin at higher risk for skin breakdown, since it lacks the building blocks for healthy skin. Another cause is our diabetic neuropathy, the lack of sensation with our diabetic patients, and the lack of skin perfusion due to that thick, syrupy blood, so we end up with foot ulcers, which are very common. And lastly, clients with liver cirrhosis have low albumin. The lack of albumin, which is that protein that attracts fluid back into the vascular spaces, so we end up with a bunch of fluid that leads to edema, basically waterbed skin, so a high risk for skin breakdown. Now, in terms of the 6 stages for pressure injuries, make sure to focus here on the pictures. The NCLEX and exit exams love to show pictures and ask you to name the stages. So stage number 1, we have red skin that is intact and only affects the epidermis, the outermost layer of the skin. So just think only one layer of skin damage for stage 1. Now it's non-blanchable, meaning that it does not turn white when pressed on. It stays red. Now if it is blanchable, then it's not a pressure injury yet. Now for stage 2, the skin breaks and we have an open wound, but just affecting the top 2 layers of skin, the epidermis and the dermis. So just think 2 layers of skin damage for stage 2. The wound bed is red or pink and shiny or dry. Now for stage 3, we have full thickness skin loss, extending into the subcutaneous, that fatty tissue that kind of looks like bubble wrap. The wound may be tunneled under the edges of the wound bed, so just think 3 layers of skin damage for stage 3. Now stage 4, this one is the worst. It extends all the way down into the muscle, bone, or even tendon. So just think 4 layers of skin damage for stage 4. Now the unstageable one, huge NCLEX tip here. We have full thickness skin loss with 2 key signs to write down. S-char, which is known as black or brown dead necrotic tissue. So just think S-char is like coal because it's black or dark brown. And the second key term is slough, described as yellow and stringy. So I'd recommend writing these 2 down. Slough is that rubbery substance looking kind of like chicken skin. So think slough is like stringy chicken skin. Take a good long look at this nasty picture here. A lot of questions ask you to identify this one. Now, since there are 2 colors that are preventing visualization of the wound bed, it's classified as unstageable. These wounds typically need to be cleaned out or debrided in order to visualize the wound bed before a stage is made. So Hesse mentions, the nurse is assessing the skin of an immobile patient. Skin covering the sacrum appears to have full thickness loss, but the wound base is covered in black S-char. How does the nurse document the finding? Unstageable pressure ulcer. Now our last one here is a deep tissue, which presents as dark purple and will sometimes come open. The fatty tissue is injured below the skin. Now it's not typically tested, but I would be familiar with this one. Now in terms of the treatments, it really depends on the cause here. So for clients who are bedridden, we must first assess the skin and document, especially within the first 24 hours of admission. If not found and documented within the first 24 hours of admission to the hospital, then the hospital assumes responsibility of the wound, even if it's not the hospital's fault and not even caused there. So a full head-to-toe skin assessment is priority. We must take a picture and document and stage any wound upon admission. Next, we must turn every 1 to 2 hours, especially clients with high risk, like those who are bedridden. So make sure to write it down. This is done every 1 to 2 hours to relieve pressure on the bony prominences. Now Kaplan mentions, the nurse is teaching a client with a stage 1 pressure ulcer on the greater trochanter of the left hip. What should be included in the teaching? Change position every hour. Now in terms of nutrition, protein and fluids are priority here. So fluids at least 2 to 3 liters per day. This helps to build and maintain healthy tissues. Now, how do we know if the client has adequate fluids? Well, we monitor urine output. So write this down here. Urine output 30 mLs per hour or less. This means that the kidneys are in distress. Or in this case, it means we have less than adequate hydration. So Kaplan mentions, which finding contributes to delay wound healing in a client with a stage 3 pressure ulcer? Urine output 25 mLs per hour. Yes, it has to be at least over 30 mLs per hour. Now, albumin is another key factor here. So albumin normally should be between 3.5 to 5.0. Remember, albumin attracts fluid back into the vascular spaces to prevent edema, that waterbed-looking skin, and help the body maintain healthy tissues. So just be sure to write it down. Albumin must be between 3.5 and 5.0. And lastly, we're always monitoring any pressure ulcer. We're looking at the stage, the size, and the color. And we can even use a key term, Braden scale. This is a rating system used to monitor risk factors for skin breakdown, which is typically done every shift. So just think the BS for Braden scale monitors risk factors for BS, broken skin. All right, that wraps it up. Now for the practice question on pressure injuries. Question 1. Which client is at highest risk for development of pressure ulcers? So go ahead and pause the screen and try your best to answer this question in about 60 seconds or less. Now, following the question breakdown strategy. Number 1, we always look at the key terms in the question. So key term is highest risk and pressure ulcer, also known as pressure injury. And number 2, think of a few things you know about those key terms. So for pressure injury or ulcer, this is that skin breakdown. We know from the full video that the big risk factors, number 1 is being bedridden for a long time. And number 2 is incontinence, followed by poor nutrition, diabetic neuropathy, and liver cirrhosis, resulting in that low albumin. So now let's look at the options. Option A, a 65-year-old female client scheduled for an elective hysterectomy. No, this is incorrect. This client has chosen this elective surgery to remove her uterus. It sounds like she's lower risk since she can make her own decisions here. But let's look at the other options. So option B, a 55-year-old male client who experienced a heart attack with an order for bed rest. Ooh, this is close, but probably incorrect here. Because ordered bed rest after a heart attack, we can assume that the client was active before. But again, let's look at the other options. Now, option C, an obese 70-year-old female client diagnosed with hyperglycemic hyperosmolar non-ketosis. Woohoo! Big long word for HHNS, that type 2 diabetic problem. Now, this option was pretty tricky. Sure, the client is obese, they're 70 years old, and in a diabetic crisis. But option D is the most at risk. So option D is the most correct. So let's break it down. An 80-year-old thin male client with low albumin who is confused to person, place, and time. Yes, this is the most correct because look at the key terms here. We have a thin, old client who is the oldest out of all the options. He has low albumin and confused. So this client is likely to be bedridden with possibly having incontinence with poor feeding due to the confusion. So option D would have the most risk factors here. Now moving on to question number 2. The nurse performing an assessment on a newly admitted client notes a lesion on the client's right heel that appears as a shallow open ulcer with a pink wound bed. The nurse will document this as a fill in the blank. So go ahead and pause the screen and try your best to answer this question. All right, let's break this question down. Following the question breakdown strategy. So number 1, first look at the key terms in the question. Question states lesions on the right heel, shallow opening, big key term is open, with a pink wound bed. So think of a few things you know about those key terms. Well, We know that stage 1 is a closed pressure injury. Stage 3, on the other hand, is deep into the subcutaneous, looking kind of like bubble wrap, which is not the case here, so it must be stage 2. So option B would be the most correct, as it is shallow, open, with a pink wound bed. All right, that wraps it up. Thank you so much. This is an autoimmune disorder where the body attacks normal healthy tissue, causing rapid cell division in epidermal cells, the skin cells, resulting in some very key signs and symptoms. So write these down. Silver plaques and reddening skin. These skin plaques present as rough with raised flat tops, typically found on the scalp and the creases of the body, like the knees, elbows, and even buttocks. So Hesse mentions plaque psoriasis. The nurse would expect to see which type of lesion? Elevated lesion with rough, flat top that is greater than 1 centimeter in diameter. And a second question, plaque psoriasis. The patient demonstrates an understanding of the disease by stating that the symptoms are caused by which change in normal skin? Rapid cell division. Now, in terms of the causes and risk factors, a psoriasis flare-up or exacerbation is typically triggered by an irritant that heightens the body's immune system, making the body attack itself. So triggers include food allergens, trauma, and the 3 S's. S for stress, sickness, and even sepsis or infection. Not sun exposure. Many students get this wrong. This actually helps to slow the turnover of skin cells and limit the flare-ups. So remember, not sun exposure. All right, that wraps it up. Thank you so much for Now for skin cancer. This is uncontrolled growth of cells within the skin, and we have various types. So basal cell carcinoma is the most common, but it's slow growing and rarely spreads. Squamous cell carcinoma is the second most common, and Kaposi sarcoma, which is a huge NCLEX tip. Write this one down. We see patches or lesions of abnormal tissue growth that look like purple, red, or brown skin blotches. So just know these key terms here. And the last one is melanoma, which is the deadliest form of skin cancer, since it spreads very quickly, involving moles. So we call it molenoma for melanoma. Now Saunders mentions, a client diagnosed with melanoma, which statement by a client indicates that education was effective. It is highly metastatic. Now to define some terms, a mole is called a nevy, and a tumor is called a neoplasm that develops if there is a DNA mutation. Now, some tumors can remain benign and stay well contained, while some become malignant and very deadly. So the memory tricks, just think benign is like be nice. It's non-deadly. And malignant is very malicious, very, very deadly. So be sure to write that down. Now, metastasis or metastasis means that the cancer is spread to other locations in the body, as mentioned before. Like when a malignant tumor gets inside the nearby blood or lymph vessels, it can travel from the primary site to the secondary site elsewhere. Now, in terms of signs and symptoms, screening for skin lesions is the biggest key point. The key here is prevention, so we must educate clients to be vigilant on screen lesions. Anything that is changing in size, color, or dimension is bad, and typically means that it's malignant or deadly. So the A, B, C, and D are the biggest NCLEX tips for screening. So write this down. A for asymmetry. Just think irregular is bad. Or think irregular is not regular. Something is wrong here. So a half raised or half flat that is not round, then we have asymmetry. So the key terms here, half raised and half flat. This is bad. Now B is for border irregularity. Remember, irregular is the key term, with uneven edges, so write that down. C is for color variation and changes. We do not want a mix. So a mix of brown, tan, black, and even red, or the worst here, a black or dark lesion are typically indicating of necrosis, not a good sign. And D is for diameter, anything over 6 millimeters. Commonly described on many question banks as lesion is the size of a coin or a nickel. So just think the size of a nickel is over 6 millimeters. And lastly, E is for evolving, changing in size, shape, and color. Remember, any type of change in size, dimension, color is a bad thing. So write these down and focus on the highlighted ones here because these key terms came up a lot on the NCLEX. Now another big NCLEX tip is the key terms, irregular or uneven growth. Remember, this is bad. And even change. A lot of question banks use the key terms abrupt, sudden, or rapid when describing color, size, and shape. All these key terms indicate that it's bad for the lesion. So teach clients to report to the HCP for a follow-up immediately. This could mean deadly malignancy. Now, a little side note here. A full workup for every single mole is not necessary. Only the ones that are changing or have uneven growth or irregular growth here. So Hesse mentions, the nurse notes widespread nevi across the body, which characteristic, if demonstrated by one of the nevi, would cause the nurse to be concerned about malignancy. Irregular border. Yes, we want a round border. Anything that is irregularly shaped is bad. Now, in terms of diagnostics, a tissue biopsy is required to make a definite diagnosis of skin cancer. But again, the key term here is that all new growths and pigmentation do not need to be biopsied to rule out cancer. Only the ones that show irregular changes, as mentioned before. Now, for the causes and risk factors, we have environmental or genetics. So for environmental, the big NCLEX tip is exposure to UV light. Now this is the most tested since it's the most common. So we want to avoid tanning beds. Write that one down. Like the old Jersey Shore TV show here. Gym, tan, and laundry. No. No tan, just the gym and the laundry. Now, sun exposure is another key term. So write this down. Frequent sunburns as well as an outdoor occupation. Huge risk for skin cancer. Now for genetics, the NCLEX tips that we highlighted below, I'd write these down. Family history of skin cancer, like a father or mother with melanoma, and even Caucasians with light skin, blonde hair, and freckles, due to the fair skin that is more easily burned. And a high number of moles. This indicates a big risk for skin cancer. And lastly, the use of immunosuppressant medications, like HIV medications and long-term anti-transplant drugs, which lowers the body's ability to defend against cancer. So I suggest pausing the screen and writing down the highlighted ones here, as these are the most tested out of 5 different textbooks. So Hesse had a question, what would the nurse advise a patient to avoid to minimize the risk of skin cancer? Tanning beds. Yes, we want to avoid the tanning beds. All right, that wraps it up. Thank you so much for watching. Don't forget to take fungal infections is the next topic here. Also called tinea or tinea or even Tanya. I'm just kidding, not Tanya, just tinea. Anytime you see the word tinea, just think fungal infections. The most commonly seen is tinea corpus, that ringworm infection, as well as tinea pedis, basically athlete's foot infection. Both are very contagious fungal infections that live on the surfaces of skin. So Hesse mentions tinea capitis, tinea corposus, and tinea pedis. All the tineas are examples of which type of infection. So remember, tinea, just think fungal infection. Now for signs and symptoms, we have a circular rash that looks scaly and even itchy, also known as pruritus. So Hesse mentions a patch of skin that itches on the right forearm, a well-defined circular rash with a red border and clear center. The nurse anticipates a diagnosis of which skin disorder? Tinea corposus. And a second question. A patient with tinea pedis, that fungal infection of athlete's foot, has increased moisture and pruritus around the toes, that itchiness. Which instructions does the nurse give? Select all that apply. So write these down. Wear cotton socks to absorb moisture. Use warm water soaks for the toes. Keep the toes clean and dry. And soak the toes in Burow's solution to help with this fungal infection. Now, for education, the biggest piece of advice is not to spread the infection. So those who have the infection can easily spread this via direct contact with humans or even animals. So the big key point and priority for any type of tinea, especially tinea corposus, that ringworm, write it down, most important to teach ways to prevent the spread. Ringworm is easily spread and highly tested on. So we must educate clients not to share personal items like brushes, towels, hats, clothes, or really even anything else. And we always wash all the bedding and sheets before infecting another person in the family. All right, that wraps it up. Thank you so much for watching. Don't forget to... Now for inflammation and healing. Inflammation is not the same as infection. So the causes is actually infection. Like, for example, stepping on a rusty nail and not treating it. The foot will blow up and get inflamed. Another cause is autoimmune disease, like rheumatoid arthritis, where the body attacks the joints during times of flare-up, causing massive inflammation. Now, another cause is allergic reaction. For example, getting stung by a bee and blowing up and getting all puffed up with inflammation. Or eating something you're allergic to and the face inflates. And lastly, another major cause is trauma, like a sprain or a break, like twisting a knee or an ankle during a basketball game. Whatever the cause, the body typically reacts very similarly. So local effects include redness and warmth, edema, as well as pain, loss of function, and exudate. And systemic effects, we have mild fever, malaise, or a feeling of discomfort, as well as fatigue, headache, and even anorexia, that loss of appetite where clients don't want to eat due to the massive inflammation. All right, that wraps it up. Thank you.